So let's just start going around the table as to who's with us this morning. Anne, if you wouldn't mind starting, please.
Good morning. Thank you, John. My name is Anne Culpepper. I'm COO of Illumisoft, and our team member, Alicia, will be presenting later this afternoon. Really excited to be here. Thank you, John.
Great, thank you. Sonia?
Thank you. I'm Sonia Hall. I am the president and CEO of BioKansas and the founder of Innovation Festival. And I'm looking forward to sharing some information about our efforts to grow innovation in the region.
Great. David?
Hi, I'm David Moran. I'm a physician and professor at the University of Health Kansas City at the Lakewood campus. And my interest has been in data analytics and helping train new physicians.
Alfredo?
Hi, I'm Alfredo Garcia. I'm with the team at Illumisoft and thankful to everyone for participating today and looking forward to the conversation.
Great. Marie?
Hi, I'm Marie. I am also on the team at Illumisoft, and likewise, I'm excited to hear about Sonia's presentation and looking forward to Alicia's presentation as well.
Great. Todd?
Todd Oink, On and On. We do 3D mapping.
Jim?
Jim Starsiv, I'm the program manager for Solutions Lab at KC Digital Drive.
And Aaron?
Aaron Deacon, Managing Director at KC Digital Drive.
William?
Hi everyone, William Crumpler, Program Analyst with KC Digital Drive.
Derek?
I'm Derek Scherer. I'm heading up an open source software project. It's a Corpusm 3D interactive, immersive, medical and biological software using video game technology, procedural generation, and database interactions.
Great. Alicia?
Hey there, I'm Alicia. I'm also with the Illumisoft. I'll be presenting later on today, but I'm also really curious about Sonia's presentation as well. Thank you.
Mike?
Mike Mitchell with Unite Us. We're a social determinants of health and health equity infrastructure and software company. And I'm going to be on mute the entire time because we've got a house full of COVID with kids and babies running around. So
oh, no.
Stay safe out there, everyone. We avoided it for 2.5 years, but here it is.
All right. That's unfortunate. Thanks, Mike. Allison?
Hi, I'm Allison. I'm a CRE project manager with the Illumisoft team.
CRE is like client's result executive or?
Yes.
Okay, thanks. Doug?
I'm Doug Hohulan. I'm with the KU School of Nursing as a volunteer faculty member and working on immersive technology.
Great. Daniel?
I'm Daniel Kennedy, Vice President at BioNexus KC. We're a animal and human health ecosystem building nonprofit. And I think that Mike Mitchell wins best background if that really is on the back of his wall.
It's in our office in New York. It's not actually my wall, but it is a real wall in our office in New York.
That's great. That's great. Dan?
I am Dan Prance. I'm also with the Illumisoft team.
Great. Welcome. Anurag?
Good morning. My name is Anurag Patel. I'm with Abata Health. I'm the CEO of Abata Health, and I'm also part of the health team here at Kansas City Digital Drive.
Great. Steve?
I'm Steve Kropp with the University of Kansas Health System.
Director of telehealth, correct?
Director of Telehealth. Yes, thanks, John.
Yeah, thank you. Doug, all right, yeah, Doug, let's go to Matt, please.
Yes, sorry. Matt Heelan, I'm actually with the Illumisoft team as well.
Great. Scott?
Good morning. I'm Scott Gunnagle. I've got a ball cap on. I was with Microsoft in Mayo Clinic yesterday in Chicago and got home late last night because the airlines don't like to fly home. So I apologize about the ball cap.
I'm with a company called MetaView. We're a mixed reality solutions provider that has presented on this call before, and we are the interface between diagnosis and intervention to democratize expertise throughout a more broad constituency. Thank you.
Great. Lucia.
Hi, good morning. This is Lucia. I'm the Associate Director for Social Determinants of Health for United Healthcare, one of the Medicaid plans in Kansas.
Great. Welcome. Lori.
Good morning. I'm Lori Erickson. I'm the Director of Remote Health at Children's Mercy.
Great. And Gary.
Hi, good morning. Gary Carnes, the Telehealth Program Manager for the University of Kansas Health System.
Great. We have a couple more people to admit. Just a moment, please. Robert, oh, he's not on audio yet. Robert, would you like to just quickly introduce yourself?
Sure. Sorry I'm late. I'm Robert Stiles with KU School of Medicine Department of Pediatrics with the Telehealth Rocks program, which does telehealth and other teletraining throughout Kansas to school districts and clinicians.
Great. Welcome. Dennis, could you say hi?
Hey everybody, Dennis Ridenauer, CEO at BioNexus. Just getting settled. I'll be on camera here in a little bit.
Great, thanks, Dennis. Okay, that's a great group this morning. Good to see you all. And I think we should go ahead and start right away. I'd like to introduce Dr. Sonia Hall, CEO and President of BioKansas, and our presenter today to look at various different things. First, the Innovation Festival that's coming up, which is kind of an exciting event and a new kind of approach in the Kansas City area, and also to reflect a little bit about the direction toward biologics and in the work that's being done in Kansas these days. So, Sonia, please go ahead.
Great, thank you very much for the opportunity. I'm going to share my screen here. All right, hopefully you can all see that there.
Yes, it looks good.
All right, so I'll start off with our Innovation Festival. And John, thank you for the opportunity to share this with everyone today. So Innovation Festival, it's a 3-day event. It's really designed to be an economic, workforce, and community development effort. What we want to do is bring people from across the Midwest and even some from the larger country to celebrate the role that the Midwest has had in driving innovation, whether that be in health, whether that be in agriculture. We just want to bring people to the festival grounds so that they leave with this undeniable understanding that innovation is what we do here. So the first 2 days are set up as conferences. So the first one is an Innovations in Ag Tech conference. And so here what we've done is brought in over 100 innovators from around the Midwest to talk about the innovations that they've created, talk about the direction that their fields are headed in, also look at some product demonstrations. And the underlying goal of the Innovations in Ag Tech conference is really to start to build partnerships and awareness of the opportunities that are available here. So getting them to understand that there's organizations like Plug and Play that have this accelerator, that, you know, Kansas State University has just this expertise within biosafety, biosecurity, especially within that agricultural space. And so if you visit the website, you'll see that we have a large number of speakers that kind of are from across the country, really, that'll just be speaking and then doing those product demonstrations outside as well. The conference schedule builds in the opportunity not just to hear from these speakers, but then to network with them afterwards. There's also some opportunities to meet up within the city, whether you're attending the conference or whether you're just part of the community. So if you check out that schedule you'll be able to see where the pop-up networking is each night, and you can kind of come and meet with some of those innovators as well. So we're really excited about that. It's almost sold out. We've only got 22 seats left as of today, so we're anticipating that'll be sold out by Friday. The second conference is one that I'm really excited about. This is our Mechanisms of Disease Research and Recruitment Conference. So if you remember at the beginning, I said this is an economic, workforce, and community development effort. This is really where that workforce development strategy comes into play. So here we've brought in scientists from around the country that are highly technically trained in areas that talent is needed by our industry, whether it's private sector industry or within our academic institutions. So we've taken the time to carefully match these students with area companies and academic institutions where their technical skills make them a good fit to either work or train. They have an opportunity to present their work. So you'll see there's a large number of speakers that are both established faculty, industry professionals, and early career scientists. So throughout the day, there's a number of oral presentations that will take place. There's also a poster session that happens, and that's where they'll get to also meet with a lot of the exhibitors that will be on site. And then there's some really unique aspects built into this conference that allow these companies and academic institutions to really get to know this talent that's emerging into the job market. So the first night for all of the graduate students and postdocs and sponsors, we actually have a dinner at Boulevard Brewery where they can kind of see the skyline of Kansas City. What we really want to do is embed them into the vibrancy of the city so that they understand what it might look like to work or train here. And so there's a lot of really cool kind of aspects that are built into this. We really want to demonstrate the experts that we have here in the region. So you'll see that there's also a lot of speakers from the University of Kansas Medical Center, Stowers Research Institute, UMKC, and a variety of others. We want them to understand that we have really great, outstanding scientists and researchers here as well. And then there's also showcases showing some of the industry companies that we have here and what they do. We hear often that there's a lack of awareness of what the job opportunities are that exist within private sector industry amongst graduate students and postdocs in particular, and also undergraduate students. So we're using this as an opportunity to not just provide that educational content, but also to kind of really expose them to what those opportunities look like here, since it's really challenging for us to be able to secure that talent. And then we have a number of activities and efforts that we do throughout the year that kind of layer on top of that conference to kind of strengthen those bonds between individuals that have been at the conference and that allow us to continually engage with them. So all of those attendees then spend their final day at Crown Center, and they're coming together for a music and innovation festival. So here we have national musical acts as well as regional and local acts that will be on that main stage. And then in between each of those acts, we're featuring innovative companies and technologies that either have emerged or are emerging out of our region. So Jim, who's here with us today, will be one of the speakers on the main stage. And what we really want to do, like I said, is just leave that undeniable understanding of what it is that we do here and how we're innovative and the impacts that those innovations can have more broadly on the community. In addition to the musical performance, our tagline is Beats, Beer, and Biologics, and that's because we're hosting a brewery showcase. So again, thinking a little bit more about that economic development opportunity that this event presents. We want Kansas City to be a destination for innovation, for music, and for beer. And so we're showcasing 11 breweries from across the Midwest, and we want people to understand that they're the original biomanufacturers. And while people think that working in an innovative industry or working within the biosciences isn't necessarily for them, we want them to realize that they still interact with our industry regularly. And so the brewery showcase is kind of our way of starting to demonstrate that. So the different nodes of this festival speak to different audiences and different people that will be there. Since there's 5,000 people, there's a lot of opportunities to engage people in different ways. We'll also be doing our biologics reveal. And I'll talk a little bit more about what the biologics effort kind of looks like moving forward. But this will be the first opportunity where people will start to learn a little bit about why Kansas City has a distinct competitive advantage, kind of the positioning that we're looking to take in growing this industry subsector, and why it's so important for increasing health equity and increasing equity and opportunity and economic prosperity. And so that's kind of our innovation festival in a nutshell. I'm really excited about the innovators that we're showcasing on that stage. We have one speaker, Stephanie Nowarski from Stowers Research Institute, who will be talking about the intersection of science and art. So I think it'll be a really exciting kind of time. So John, I can pause there for some questions on that if you'd like, or I can just jump into the biologics work that we're doing.
I think maybe if we'll go ahead and do the biologics work first, and then we'll have some general questions. But it's clear that the festival is very unique and very exciting, and beer is my favorite biologic, so I find it very interesting as well. But please share with us a little bit about the direction in biologics, and to the extent that you're able, and we'll follow up with some questions.
Great. So back in 2019, I came to this region to build this vision that I had for the biologics sector and Kansas City. Biologics are essentially the cutting edge of pharmaceutical medicine, and they create the opportunity for us to realize the potential that personalized medicine has, where we have to take into consideration not just the individual genetic composition of, say, a tumor or an individual, but also the lived histories of that person and how those complex factors influence the way that their body responds to treatments, therapies, or the environment around them. Kansas City, we identified in partnership with Casey Rising as having a lot of very distinct competitive advantages. So within our region, we have highly specialized design and engineering firms that can build these facilities that we need in order to be able to grow the infrastructure. People from around the world come to Kansas City to obtain this expertise to build these structures for them. And for us, it's right here in our back door. Our backyard, that was the wrong phrase. I'm really bad at like catchphrases, sorry. That's why I'm a scientist. Maybe I'm too nerdy for tests or catchphrases. Additionally, we have a lot of supply chain, warehousing, and logistics assets that exist here. The fact that we're here in the middle of the country means that the number of obstacles that we face to get a biologic from the point of production to delivery to the end user are much lower. And there's just a few places in the world that have that advantage of being able to reach a larger population of the world in a shorter period of time for those really highly sensitive biologics. The research expertise and capacity that we have here, K-State, their work with NBAF, the work that they have, leading biosafety, biosecurity of the food supply and agriculture allows us to be dominant and gives us a competitive advantage clearly. We also realized that a lot of the talent within our area that works within manufacturing actually only requires a small reskilling and retraining in order to work in these, I don't want to call them more specialized. There's plenty of really specialized environments within manufacturing settings, but kind of these more environmentally controlled settings. And the path forward to be able to do that reskilling isn't very complicated. And so, what we can do is, as the manufacturing workforce has to shrink, we can absorb them into the biologics industry, biomanufacturing workforce, with just slight investment in reskilling. And those jobs that we have within this region right now, and even as we continue to build it, will lead to greater equitable prosperity for individuals across the region. So the majority of jobs that we identified working with Brookings and Casey Rising were either good or promising jobs. That means that these jobs either will lead to a job or already are a job that pay a minimum of $23 an hour plus employer-sponsored benefits. Whereas most of the other industry sectors that we looked at, the majority of jobs that they had were other jobs that didn't provide that durable wage, and also didn't provide the opportunity to grow into that durable wage within 10 years. The only industry sector that exceeded biologics for having high wage growth opportunity for individuals was cybersecurity. But again, the number of jobs that were available in that were quite small as well. So we decided with Casey Rising that we were going to undertake a 7-part strategic plan. And we worked with a number of community partners, including BioNexus KC. So I think Dennis and Daniel are both here today, to collect some data, begin to understand exactly where we are. Can we quantify it? Can we come up with a roadmap forward? And while doing that, can we set some strategic goals in place that we know that we're heading in the right direction, or we know the path for course correction if we're not? The thing that we did that was distinctly different than what most other groups do is that we started by doing an industry-wide regional equity assessment. So we collected data to truly understand, what does it mean to have an equitable and inclusive industry cluster? What does our equity and inclusive environment kind of look like now? And how do we fix the things that need to be fixed? And so that equity and inclusion is the basis of every single thing that we will grow moving forward. When we talk about growing equitable economic prosperity, it's the foundation that guides every step forward. And I think that that's rather unique. And that's why when we talk about growing the biologics sector within the region, we say that we want Kansas City to be the most equitable hub for biologics research, production, testing, development, and distribution than anywhere else in the nation. I think if we can do that in one of the most racially segregated cities in the country, that demonstrates that if we take that approach, we can do it anywhere. Within the biosciences, the majority of individuals who have diverse lived histories, they attrit out of our training and our career system quite rapidly. And so we need to identify not just ways to build an ecosystem that's equitable and inclusive, but where it's focused on retention. We can attract people all day, but if we can't retain them, then we can't have that industry growth that we need. So we have a lot of very specific efforts around that that we'll be working on moving forward. We have an exciting announcement that's coming out this fall that we think will be a game changer for our region as well. So I think I'll stop there and just take any questions that people might have.
That's really great, Sonia. I particularly like the focus in the festival with respect to students and the way of getting them linked up, as well as how you promote it to outside visitors, even if it's a component like the dinner at Boulevard. It all kind of hangs together as a piece and makes for a very effective engagement, I believe. So congratulations on that. It really just seems like a great thing.
Thank you.
I
will say,
go ahead, please.
Sorry. I will say the majority of our attendees of the conference are either 50 miles or more away from Kansas City, where they live and work every single day. So that's a large amount of tourism dollars that we're bringing into the region as well, which has served us very well when we're talking about applying for grants and getting support from different investors around the area. And right now, about 18% of our festival attendees are from outside of Kansas and Missouri, so even further out.
Oh, that's great. That's great. I won't take up any more time here. Allow the group to ask questions or make comments.
Sonia, I'd asked two questions on the chat. One, are there any kinds of biologics that in particular that you think are reaching a focus on? And the second, if you could just say a little bit more about that data collection for the equity work that you're working on.
Yeah, definitely. So for biologics, the very first biologic that really kind of revolutionized our thinking about what's possible in that space was actually a vaccine, right? A smallpox vaccine, which is becoming more and more relevant still today. Diabetes, the insulin that diabetics use is also a biologic. It's probably one of the most in-demand biologics that you'll find. Here in the Kansas City region, we have one company called Licarda who is working on, they're working on trying to cure diabetes. And they recently published a manuscript where they demonstrated that they were able to cure diabetes in dogs on their way to human trials. And so that for the Kansas City region, I mean, you can imagine with the amount of money that therapeutics for diabetics and insulin cost on an annual basis, if Kansas City has a company that's producing a therapeutic that addresses some of that need, right? And if we can talk about, it can be a treatment, right? And over time, we know that it's a cure. If we can get even just to a treatment point, some of that revenue from exporting those products from this region will have a significant impact. But if we get to a cure, not only are we talking about an economic impact to the region, but a major change in quality of life for the individuals that are impacted by that disease. There's also a lot of immunotherapies that exist to specifically target cancers. So rather than having this broad assault on the body from chemotherapeutics and radiation, imagine if you can target something directly to that tumor, and that is the only thing that receives that treatment, and the rest of the body, stays in that state of homeostasis. So hopefully that answers your question a little bit about that. As far as the equity analysis, did you have any specific questions on that?
Just tell us a little bit more about the data collection. So did you work with partners who had the data and you collected it from all those partners and synthesized it? Did you go out and collect the data yourselves? Just a little bit more about, I'm interested to know where the data came from and how you pulled it all together.
Yeah, so we worked with Diversity Science, which was like a dream come true for me because they're just such a great group to work with. They undertook the data collection and the data analysis for what we were doing here within the region. I've spent 8 years doing a lot of scholarship. Great, thank you.
All right, thanks.
Sorry for the brief interruption there. I just took an electrical hit here in my house and it kicked me off entirely. I was very pleased to see all of you still here when I came back. I'm glad it didn't have the same effect on you.
Well, what we've done is edit out my self-serving questions, so thanks for that.
No, that's quite all right, Derek. It's really, so much of what we do is really about connecting with people and making those connections meaningful. So it's great for people to be able to have those kind of exchanges. Sonia, well, I think we maybe had a comment from David Varan, if he's still here, about some background reading for people who are interested in this area. David, do you want to share that, please?
Yeah, I'm sorry. I was eating a little bit late at breakfast and didn't want my video and show what I was eating. But anyway, a few months ago, I read a very good book by Isaac Walterson on Jennifer Doudna and whole CRISPR competition and how individual researchers around the globe can collaborate together. And I was wondering if are there similar stories to the competition that was really inherent behind a lot of the CRISPR stuff leading up to the vaccines happening right in front of our face and we're not aware of it.
Yeah, so I think you'll have to stay tuned to hear some of those stories. We definitely have some. I don't think we have as many as some other areas might have when it comes to competition, just because of the number of companies that we have here. But if we look at the ecosystem across the country or across the world, we definitely do. I think the one that we're going to see emerge more quickly in the near future is Lacarta, because there's a number of people that are trying to use these special delivery mechanisms in order to be able to provide these treatments, specifically for diabetes. They have additional things that they work on, but that's the one that I think will be the one that we'll see the most competition come forward with. So we need to be documenting that history now to move forward with it.
Great. Other thoughts or questions from the team? Well, Sonia, I guess that's left us with much to think about. And Jim Starsiff was kind enough to share the link to the site in the text in the chat. So if others are needing to get to the information on the festival, it's linked in the chat. And really look forward to the opportunity that this presents for the Kansas as a state and for Kansas City as a region. So it really is a great addition, and we thank you very much for sharing it with us.
Yeah, thank you again for the opportunity. It was a pleasure to meet all of you. LinkedIn connections coming.
Sounds great. Thanks so much. Well, with that, I guess I would like to introduce our next presentation. We have a real look at something that's developing and new in the Kansas City area, a solution that was generated really from experience of the firm Illumisoft, and their team is here to help us kind of understand where they're getting with this, and also to take our feedback on what kinds of things that we see that they need or would want to consider as they move this development forward. So with that, I'll turn it over to Alicia Mullins and the rest of the Illumisoft team.
Hey there. Thank you, John, for this opportunity. As he said, I'm Alicia Mullins. I'm also a client results executive here at Illumisoft, and I'm here to show you our project OneSource. And as John said, hopefully get some feedback, answer some questions that you may have. So I'll first go through a pretty short slideshow, and then I'll demo OneSource. So, excuse me, as Derek was saying, kind of show it before it's done. This is still in its infancy and MVP stage, so it's by no means a finished product. So let me share my screen. Alrighty. Are you able to see the full slideshow?
We can see your presentation mode, so we can see like the
notes.
Yeah.
Okay. Let me fix that real quick.
Let's see.
How about now, or same view?
Yeah, same view, but go to display settings, and then I think it's select. Yeah,
there we go.
Sorry.
We go. Sorry about that. Alrighty, so so OneSource is a health monitoring solution to meet your needs. So what's the situation here? So remote patient monitoring has become an exceedingly popular and useful way for researchers to track patient behavior to interventions in real time. we know that it's been, quite big since the pandemic hit as well. So what is the problem? It's hard for providers and researchers to accurately monitor patient outcomes when they're away from the office. You have to wait 6 to 12 months, if they're lucky, for the patient to come back in and maybe fill out a form that might only be semi-accurate, maybe inflated. So of course, this issue only increases within rural areas and alternatively areas with low income populations. So that's where remote patient monitoring comes in to save the day in a way. So we have remote patient monitoring, and OneSource delivers a way for providers to keep track of these patient outcomes when the new interventions are introduced. And they do that because researchers and physicians can find trends to predict and improve health outcomes. And they do this also because we can link to Bluetooth or cellular devices, including weight scales, blood pressure cuffs, pulse oximeters, blood glucose monitors, etc., to get these readings to more accurately track health outcomes, and real-time health pieces. So early into our investigations, though, we began to think, what would this product look like if I were a physician or a researcher or a person working for an insurance company? How could I use a health monitoring platform to help better or provide better health outcomes? Maybe research and intervention or reduced costs for a patient, clinic, hospital, whichever side you want to look at. But essentially, how could we help people in healthcare achieve their goals? So we came up with some ways that we may be able to customize this. So OneSource at its core is a remote patient monitoring system as a base. And we'd like to get feedback on what is needed within the community in order to fit the needs of our population. So we've come up with some ways. So we think OneSource can be used for a variety of health disciplines, anywhere from long-term care to behavioral health, mental health in general, because it displays a wealth of information that can be expanded to fit clinical or research needs, depending on integrations or, any sort of connection to outside sources. We can connect doctors to patients in rural areas or potentially low income areas. It can be used to expedite and improve research practices. We're thinking about EMAs to improve patient experience and health outcomes. And then, so on and so forth here. We can expand it to give patients insight to their own health outcomes and health trends. So, patients don't quite feel like in the dark, and they're aware of their own health and be able to see those trends themselves. And of course, integrating with EMR and EHR systems like Epic and Cerner, connecting with other health apps, and perhaps any analytic services. So this is kind of another way to summarize that. You could plop yourself down anywhere on this map and take an Uber or a Lyft, whatever your preferred communication or transportation is, to any one of these places. And this is something that, we would build upon for your need. So anywhere from, as I said, connections to Epic and Cerner to maybe Power BI. We're also looking into automated research processes. And of course, administrative stuff like SSO and customized branding. So these are pieces that we are looking into and we would love your feedback on. Alrighty, so that's my short presentation. So now going to, are there any questions before I move on to the demo?
I think David Rand had a little bit of a comment about the patient engagement aspects of it as well. David?
Well, yeah, we have about 100 patients involved in RPM at any given time, and another 300 or so involved in asynchronous RPM. And I think what we've observed is that the patients start connecting the dots if they measure themselves on whatever measuring their tool they're using, and they start making behavioral changes that will augment any kind of treatment interventions long before providers do. And what they've reflected back to me that's needed is a way for them to connect with other patients on RPM, not only in our system, but globally somewhere else, say in another hospital system that's doing this. Right now, the limiting factor in RPM is Medicare is the only beneficiary that consistently reimburses this. So figuring out a way to broaden this so that more people can participate is something that I think everybody's looking for. And Illuminasoft's efforts in this area, I think, are potentially a game changer.
Thank you for that. And when you say connected to other hospitals, you mean providers connecting with other
Yeah, I
providers?
mean, because I don't know how many across the Kansas City area are doing RPM, but my guess is it's many times more than the 100 that are in our organization. And so, figuring out a way to at first anonymously have a place for patients who are involved in RPM, and usually through third-party vendors that protect that data from HIPAA resources and everything else. I think we need a different approach that allows a person to participate with other people that have similar conditions that may be in a remote monitoring program at another facility or another country or widely diverse, to share what are they noticing between their daily measurements and their lifestyle or their medication treatments, and have that much more collaborative approach as opposed to an individual provider or individual system.
Yeah, thank you for that. Thank you for that feedback.
I have another comment. Anna, if you want to quickly introduce yourself, it was great you were able to join us along the way here, and ask your question, please.
Hi, yes, I apologize. I'm calling you remotely. I've kind of got a busy morning going, but my name's Anna. I work with Modern Health. I'm a nurse and nurse manager for our telemedicine services. So I just had a quick question for you. I think it was fascinating to hear about your guys' goals and everything that you're doing with RPM. And I know it's a vastly growing field. So I was just curious, is your platform more patient driven, or would you say there's a clinician behind the platform?
Well, I would say in a sense, both. I mean, right now, and as I will show you in a few moments, we don't have a patient portal quite yet. I mean, it's driven by patient data, but it's at this time for clinicians, physicians, researchers. That's what it was initially built for, but we are looking out more towards something more patient driven. What does patient driven mean to you?
Oh, I was thinking more on the user end. So the end user, you say it's the physician or the clinician itself that's taking the data and extracting it and then reaching out to the patient. Is that right?
Yes. So that is how we currently have it, but we're, working right now on creating a patient portal.
Yeah,
So,
absolutely.
Yeah.
Fabulous. Thank you so much.
Of course. Thank you.
Yeah, Lisa, if you want to go ahead and show you a little bit of your demo, that would be great.
All right, wonderful. All righty. So here is an example of what OneSource could be as a generalized remote patient monitoring service. As I said, this is, highly in its, infancy or MVP stage. So what you see here is not the complete picture. So let's see. So OneSource currently offers 3 views. So we have a OneSource admin, which is, sort of, Illumisoft-ish. So that, managing different clinics, things like that. Then we have a clinic administrator or manager. So essentially someone who is in charge of gathering the patients, gathering the physicians, making everything look nice within OneSource. And then a physician view, which is slightly limited. So the physician view shows patients and the dashboard. And this is the clinic admin view. So it shows you, all the patients. Doctors can have their patients just, filtered. So what they see is, or who they see are the actual patients that they see. So we have flexible views here. So the user is able to move cards around and the system will remember it and to prioritize the information that's important to them. We have an overview here that shows an interactive graph, a chart. So basically you're able to see, an overview of these critical chronic illnesses within your clinic. We have critical patients here. So these patients are flagged when they have readings on their devices that go beyond the parameters that are set by the physician, which we will see later on the patient page. So based on their readings, if it's out of that range, it flags. We have billing here. So essentially it is connected using some CPT logic for Medicare. So when a patient has used, their 20 minutes, or I should say when a physician has used the 20 minutes, either in an appointment or reviewing vitals, things like that, then it keeps track of the codes essentially and what has been billed. So the end user can take that information via CSV and use it for other billing purposes. And eventually, we could integrate this with whatever billing system the clinic is using. And then we have patient reminders here. These are flagged messages for staff to alert them when a reading has not been supplied in over 24 hours. So as you can see here, we have some very late folks, but then we have, over 24 hours and it goes up in, scale, essentially. Red, danger. And then we have devices here. So devices, depending on your population, really can be useful for any population. But if we're looking at, seniors, for example, who might need more help with controlling their devices and understanding that they need to be charged or, get a new battery, things like that. Or a healthcare professional can give them a call to remind them to take care of their device. Any questions here so far? I see some in the chat. Let's take a look. Okay. David, can you talk more about your comment in the chat?
Well, let's see. traditional remote patient monitoring cannot be billed unless it's ordered by a physician. So that's a huge burden and a hurdle to make these programs and to get hospitals involved, because that has to happen first. And then there's a CPT code for that is associated with that when the device is installed. And it's relatively minimal, but it does cover some of the cost of the equipment, but not all the equipment. The barrier that we're having is a lot of the patients on remote patient monitoring are doing 13 or 14 days of measurements, and CMS requires 16. So cajoling those to get to that 16th day where you make your reimbursement is dependent on actually work is a problem. Not so much for those that are not at goal for whatever they're doing, whether it's glucose or whatever. It's those that are at goal, because once you're at goal, then there's no real motivation to measure as frequently as before. So we're seeing a drop off on patients. So about 60% of our patients who are on remote patient monitoring actually meeting that threshold. That's separate from the 20 minutes. The 20 minutes we found is a real struggle because, as you know, medicine is encounter-based. So there has to be an encounter that's a recurring encounter that spans multiple visits, as long as the patient is on RPM. And so everybody communicates with the patient in whatever encounter that patient is currently on, which is usually not the appropriate one. So figuring out a way to extract communications about remote patient monitoring from not only the RPM vendor, but from all of us who are communicating with the patient about those numbers is not a trivial task. Trying to train those that are looking at RPM to then select the RPM encounter and then document their interactions with the patient, or have the patient portal interactions with them documented on that, is difficult. And we're losing maybe as much as $100 per patient per month, because most of the interaction with the patient happens outside a phone call, let's say, in response to messages. And people, that is not trapped appropriately enough to really maximize the revenue. And so we're struggling with trying to figure out ways so that a person doesn't have to go to the patient portal or the remote patient monitoring portal to do their documentation, because then it's not an EMR. And it gets to be very, very, very complicated if you really want to maximize your revenue from this. And so any kind of thoughts you would have as to, okay, how do we track for 20 minutes? For example, I had one patient that there was 60 minutes worth of interactions between the patient and their provider, their nurses, their nurse care managers, but only 15 minutes was actually trapped in the remote patient monitoring encounter. So they lost essentially $65 that month because they weren't able to capture that and tie it together so that on audit people could track it, right?
Yeah, absolutely. That's
and I don't know of a good way to solve that encounter logic that is really undermining medicine, because patients and physicians don't think in terms of encounters. It's only the billing people and the scheduling people that think in terms of encounters, and the insurance companies.
Thank you for that.
Yeah, that's a very good point, David. I have some experience in this field as well, and that is one of the great challenges, is how do you capture the actual time being spent on the person across the multiple different ways they are engaged.
Yeah, absolutely. EMR, I know EHR, that's vital in the next step of developing this, because it just won't work otherwise. People hate to put in information and excuse me, in 2 or more different platforms. It just doesn't work, and there's pieces that go missing, including tracking time. So thank you for that.
I'd like to get back to Anne put a comment in the chat, and then I'd like to get back to maybe after we do if you have more demo.
I do.
Yeah, let's do that then, but I definitely want to get back to Anne's comment.
Sure. Or did you want Anne to go
Yeah,
first?
no, if you go ahead, we'll come back to Anne if you go ahead, please.
All right, perfect. All righty. The next 2 pages are more administrative level. So we have, users here where the clinic admin can search and sort and filter through users and, patients, whatever they may need. They can also, add a user or help them change their password or email, all that fun administrative stuff. Clinics, this is most beneficial for, those higher than a clinic administrator. A clinic administrator can really only, change the name. They can't delete anything, so no data will be lost by accident. But then here we have the patient page. So this is, the bread and butter. So we have this is a general view that physicians see right now. So, and it's really just the patients that are assigned to them. So they can see the patient name, their ID, age, and vitals. And then from here, you can have like a quick expanded view of, what their insurance is, any prescriptions that they're on, and most recent notes. And then there's also an ability to take notes from this page. So to, reduce the amount of clicking. I know that physicians don't like to click as much. They just want to be able to put in the action and move on with their day because they have so many patients that they need to see. So we're trying to make this as easy as possible to work and eventually to sync between, an EMR, EHR. So when you click on a patient, you can go to their individual page. So you're able to see, some basic information here. And the cards here are also movable. So whatever the patient or the physician really wants to see, they can. And we would love to get some information on what is most beneficial for patients as well. So what sort of information here is going to work in a patient portal? So we have, vitals charts. So the physician is able to view the health info in many ways. So they have a visual component here. They're able to show what it looks like over, a month span. They can zoom in, whatnot. They have averages. So if they just want to look at it at a glance, how is this person doing in these areas? And then they have recent vitals as well. So if we go down here, we can see more in-depth vitals. Specific if they need a specific number and they don't like, this view, whatever it may be. Also on the patient page, you're able to see some ICD-10 entry, patient devices. So you're able to, if a patient needs to change a device or register a new one, they could do that. Sonia, you have a question?
Yeah, well, it was just on the what would patients like to see
Yeah.
side of things. I feel like a lot of the times just thinking of my elderly mother that I care for a lot, they get a lot of this data in front of them, but they don't understand what that's in comparison to. So if there's like a goal, like a target range that the physician has set for people who are outside of the normal bounds, or if there is that normal range that's provided to them, I mean, you can provide a lot of information, but I feel like sometimes it could be a little bit overwhelming and worrisome if somebody doesn't know how to translate that into like action almost.
Absolutely. Yeah, I can absolutely see that, because here, there's a physician set range, but it could be also beneficial to see, what is a normal average.
Yeah, or even just where some of those individual, like where the vitals averages and things like that, where it's not in a graphical form, where they're able to just read it, because some people will have difficulty reading a graphical output of their data.
Absolutely.
Having that where it's just more easily digestible, I think could be something that's beneficial. Don't know if it's realistic, way outside of my area of work, but it's wonderful.
Thank you. Yeah, absolutely. We want to, we want it to be accessible to all populations.
Well, this is good, and I've found that most patients get really good at interpreting visualizations, graphic visualizations that are superimposed on what the normal is. But what many would like to do is to see not only their graph and what's normal, but what are other well, how do I compare against my peer?
Yeah.
There's another 350-pound, 6'2" diabetic man that, how do I compare against them? And that's the data that Fitbit used to have before Google took it over and then killed it. Because you could always compare on any one of the measures how you compared with hundreds, if not thousands, of other people in your peer group. And when I talk with patients, it's one thing to be always focused on your data, but they're really, really interested in, well, wait a minute, how does my neighbor compare? Not by name so much as what about other people my age, my race, my sex, my income level? How am I comparing against those? Because then that drives competition.
Yeah, absolutely. Thank you for that. And then last couple things here, we have a care log. So this is where we would put in notes or track time. Sorry, clicked out of that too soon. Gather CPT codes, and then also add or delete or edit medications for the patient. So that is essentially, what we have so far for OneSource. So I like to hand it over to you all with more questions, and also the rest of my team, Marie, Dan, and Alfredo can kind of pop in, and Allison.
Great. Thanks, Alicia. That was great.
Thank you.
Really appreciate your approach to soliciting some good feedback from our group here. One thing that I thought of that may be a little bit too much down in the weeds, but I was noticing the way that you do your display of your patient census or your patient list. Ultimately, these physicians will have hundreds of patients that they're looking after. And so it will be important to bring those patients for whom there are alerts to the top. And I don't know if that's function that you have already or have thought about as well, because they want a quick view of who is it I really need to be addressing right now.
Yeah, absolutely. We do have that on the dashboard view, but not necessarily on the patient view. So that is a good point. Thank you.
Okay, maybe we'd invite Anne to weigh in here with her comment, and then we'll have some further questions.
Thank you, John. I just want to call out David gave some nice feedback on the question that I had posed. And the asking about equity is something that emerged from a conversation with Mark Logan. I don't know if anybody knows Mark, but DEI consultant, who brought up what are some of the ways in which we can increase equity in our healthcare. And as we've been developing the one source product, you know, it comes to mind that there might be an opportunity here to weave that into our software. So a comment that I left in the chat was just asking those who are in attendance here whether there might be any ideas on how that could be done. And something that comes to mind to me is sort of merging whatever population data is already collected on the back end, maybe with already exists within the health record, even things like zip codes, for example, and mapping that onto other sort of equity metrics so that we can start to correlate what we're seeing within population health to other conditions. And David's comment was, unfortunately, most of the time providers don't have medicine for that. So even if they have that insight, it might not be actionable at this point in time. And I think that is a great consideration. We're still very early stages in understanding what the systemic barriers are to being able to take action on this type of knowledge, but just curious if there are any thoughts on the value of gathering it and putting it in conjunction with this health data.
Well, and we're required to do that now by many of the patients that were involved in alternative payment mechanisms. So in our monthly meetings with third-party payers, and this is primarily around our Medicaid and Medicare populations, we're required to do the social determinants of health survey on every time we see them visit. So we've accumulated almost 100,000 surveys over the last year or two. But what's really frustrating for us and for the patients is that we have the data, we see the heat map, we see where they are, but then it's like, okay, I don't have a prescription to give them an extra $100 so they can pay the rent and afford their medicines. What services are available to that block in the city that I am totally unaware of, that we can connect the patient to? There's this huge gap between traditional medicine and treatment modalities and enabling the patient to then reach out or show the patient even what resources are available, because most of the time when we get social workers involved, after a few days of digging, they find out, oh, there were resources, but the patient never applied for them, you know? And so something that for a patient to participate in this and then the patient to get resources that tumble to them would be dramatically useful and helpful, rather than having the provider to reach out and find out what resources are available to a patient who lives on this block.
So perhaps, you know, a mobile version of this that can track location, say within your area.
Yeah.
There are 3 food banks,
here's
and
here's the neighborhood church nurse that's within walking distance of where you are, that will provide resources to help with daycare, childcare, or whatever, so that you can attend to your own condition a little bit better, or take a walk, or do something. Well, we don't have that information in our clinical systems. We only have the stuff that medicine gets its grips around, right? And yes, we can toss a patient over to social work, but social workers are few and far between, and they're stretched so thin, we can't pile any more work on them. So we need to figure out ways, if we're going to lift the health of everyone, to take the information people are collecting and then empower the patient to reach out and make it easy for them to apply for the resources that only they and they alone would have access to.
Yeah, absolutely. Thank you for that.
Other thoughts?
Sorry, can you repeat that?
Just inviting other thoughts from the rest of the team.
One thing that I think, and maybe this is an uninformed opinion, but I think if there's nothing actionable that can necessarily be done right now, that it's quite possible that means that the opportunity lies in front of you, right? Like you're at the forefront of driving that change yourselves. And so I would encourage you to continue moving forward on it, because unless somebody does it, we're going to continually be in the exact same situation. I don't know. I just think that it's so important when you notice that there's a need and that there's a gap, what can you do with the tool that you're developing to address it when it comes from an equity perspective? And that can be layered on in so many different areas as well, right? Because you're thinking about applying it for this one purpose, but I think that if we opened up the 20 other doors that are surrounding you, you'd find that most others have that same need, and they would just be utilizing the data in a slightly different way.
Yeah, thank you for that, Sonia. I feel like that was a lot of our, beginning conversations. I mean, in current conversation is there's a lot of the same out there. How do we make this different? Thank you.
Some of the problems that we're dealing with medicine go back to HIPAA. And HIPAA was never intended to reduce the sharing of information. It was intended to actually promote the sharing, but we, like most people, have turned it upside down and now prohibit information from flowing. And it just dawned on me that there must be in this country 1,000 companies who are providing remote patient monitoring for several hundred to 200 organizations, or even thousands of organizations. And what's actually needed is an entity that anonymously collects the data from all RPMs and then serves it up to anybody that wants to make that stuff actionable. For example, what would be the value to the city of Kansas City if they could see the disparities between RPM results by zip code and the number of people there? That would be actionable data at the city level so that they could marshal resources to that. But right now, all of that data is hidden in provider systems and in the systems of RPMs entities. So we're somehow not, we in healthcare writ large are not doing the right things to improve the health of the country. We're still focused on an individual person, and that's like pushing water uphill.
I think part of it is also insurance companies gathering that data and then seeing, this zip code has a huge population of this chronic illness and jacking up a price.
Well, sure. I mean, there's all kinds of disincentives. For example, we've been running a pretty good remote patient monitoring program, and we wanted to expand it to Medicaid. Well, and we find out Medicaid has their own remote patient monitoring program, will not reimburse us for it, but they will welcome the referral back to them to do their own remote patient monitoring. Well, what's that? I can see that it's not going to be too much longer before every insurance company has their own RPM, right? And then we're going to be logging into every one of the patient's insurance plans in order to do anything and to get any payment back. So our incentives are not aligned to benefit a patient or a community, but individual companies. And until that changes, I think we're pushing water uphill.
So kind of to add on to what you, David, and Sonia have said, I think, and this is my perspective and something that we're working on as well, is that I agree with you guys, like in that there's too much work in certain centers that make it difficult for you to take on for like more work, especially even in the frontline sense. I think the goal of this is to try and get work outside of the most expensive and most taxed system that we already have. Right? Like my concept is like, why are we doing some of this medicine in the most expensive real estate in the city when we could be doing it closer to the patient, especially in the preventative and the chronic care space? So I think that you're right, Dr. Brand. That is hard to do. The incentives need to change. I think they're changing. We had a blip with, the Affordable Care Act that allowed that, but then it got, gutted with like the funding for it. But the goal is to look at some of this vulnerability or fragility in the populations and in healthcare, and then program match, right? So like Sonia, you mentioned like we should collect this anyways and figure out what's going on. I think this is just a glorified recommender engine. How do we look at what's consistently happening, what could be efficiently fixed, and then take it out of the traditional like encounter system and maybe work on it? And I think that's where RPM comes in play. I think it's also where mobile health comes in play, but also just ways to look at health as opposed to just healthcare, and use community health, in general systems to help with that. Part of what we're looking at is not necessarily trying to wait until we get all of those elements of fragility or social determinants of health, but maybe even start calculating that, because there have been other concepts that are doing that. There's no point in trying to say I have a verified data set and now I will start working on it. I think there's a way to say I have some of it, I can calculate it, I can predict it, and then once we have that encounter, I can verify it. But we've already gone down the path of identifying patients, identifying work, and trying to move forward on that. Those are just some thoughts, but I'd love to hear any comments if there are any. I'd love to connect with you, Dr. Rand, again, and see if we can talk about this more.
One other thing about the social determinants is that, and this may be not on target, but we have had earlier in this meeting, we had an attendee from one of the companies that does social needs referral networks. And there's kind of a presence of that in Kansas City right now. So if Illumisoft would like some connections to companies in the Kansas City area that are doing social needs referral, we can certainly help you make those connections. Whether that's just kind of learning from each other or ultimately connecting to each other, maybe that would certainly be up to you in the end. But if you'd like those connections, we can certainly help provide them.
Yes, of course. Thank you.
Yeah, well, I'll follow up after the meeting. Any other thoughts? We've really had a wonderful chance here to look at something in its nascent stages and understand the thinking that goes into it. The comments that you've all have offered have been really, I think, very much on target and very appropriate. So thank you all. Is there any other thought or question that anybody would have at this point? Okay, well, maybe we'll leave it at that for this month. Thank you very much to Illumisoft for bringing your whole team here to support a really robust discussion. Hope it was helpful for you, and hope you will continue to engage with us as you go along so that we can all be learning together and noting your progress and hoping to support it.
Thank you so much, guys.
Thank you so
everyone.
much, everyone.
Thank you.
Thanks.
Bye.
Take care now.
Yeah.